All right, Arthrogram part 3, we're going on just some information about the different sites and some specifics maybe for each one. We'll start with hips. Hip pain and question of labral tear, I think, is your main indications for a hip arthrogram. You're going to have the patient change fully. I recommend having them change completely. We have had situations where people have them change only from waist down, and then the chloroprep, or used to use betadine, will get on like the patient's shirt. So I would just change them completely. I find that to be the easiest way to do it. Hips, they're going to be supine. We're going to have their feet internally rotated, just like you would do if you're doing, say, an AP pelvis, right? To put that femoral neck in true AP, that's that 15 to 20 degree internal rotation. You're going to want to support their knees. I like that black kind of rounded angle sponge under their knees, and then I turn their toes in. I actually sometimes like put a little piece of tape around their toes, or use your sandbags next to them, so that way they don't have to try and squeeze those toes together the whole time, and then they're not tense. For your radiologist to get to the hip area on your larger patients, some of the abdominal folds may need to be pulled back, and many of them we have had to actually tape back to get it out of the way. Ideally, the needle should go through one layer of skin and not folds prior to going through the skin. So this may be a little bit uncomfortable for some of your patients. Most of them have been very great about it with me. They understand where they're at. And I just really explain that this is, the best thing for them and the least amount of needle sticks. So sometimes we actually tape that abdomen out of the way, or the patient may need to hold it up. They're going to use a spinal needle for the hip. If the patient is very large, they may need a longer one. So just be aware of that. Some just positioning tips for hip. Most of the time, our radiologists don't actually have you spin the patient to the other end. So say it's a left hip. Most of them will just reach over to the left, but it's good to ask. So if it's a left hip, some radiologists may have you put the head at the other end by the foot pedal there, or the end where their feet normally go, and so that way the left side is closest to the radiologist. For any of these, you're going to want to take your lead curtain off. That way they can get in and out underneath without hitting that lead curtain. This was just an image here of where you would see that labral tear. This is very painful for your patients, and you can see why it would make moving their hip around not smooth. Shoulder arthrograms, mainly we're looking for rotator cuffs, the joint capsule. It could be chronic pain or weakness or decrease of range of motion. The patient is usually supine on the fluoro table. Sometimes they tilt them up, so the head is up a little bit, so they might take that fluoro table and raise it. You're going to want to change them from waist up, and then they kind of take the arm of interest out of the Johnny sleeve and kind of fold it across here. It could be a single or double contrast. For us, it's usually always a single. And the shoulder is actually a big joint, so they might inject quite a bit into that joint. Depending, again, on patient size, they may need a spinal needle for this, but if they have a small shoulder, they might not. Knee arthrogram, we're looking at meniscus, collateral or cruciate ligaments, or say a Baker's cyst. The Baker's cyst is that one right behind the knee. It could be done as a double contrast, so it could use contrast and air. And they're really trying to coat the soft tissues and allow that contrast media to go into that joint space. Less common, and you guys, I don't think we'll ever see them at our facility, but TMJs I've never seen. I have seen a wrist and an elbow. I don't have ankle on here, but I've seen one of the ankle as well, and one of the foot, but that was some time ago. And again, anytime it's radiology, you can inject pretty much anywhere. So these are less rare, but also, we've seen the elbows more often for sport injuries. So a pitcher's elbow for a baseball player or tennis elbow, you might see those as well. But again, we're putting a needle into the joint space and injecting some contrast under a sterile environment. Steroid injections. So the only real difference here between an arthrogram and a steroid injection is when they put that contrast in and make sure they're in the right spot. Instead of injecting contrast for an MRI, they're going to inject a steroid medication. So hip pain is extremely common. It's in patients 60 years or older. And so they have found that the steroid injections provide both a short-term and long-term pain relief option. During the arthrogram, they use a numbing medication, which will give them a short-term relief. And then they put in a steroid medication. Hopefully, it's going to give them some long-term relief. Some patients, it helps them for months. Some patients, it's a year. It's kind of unpredictable. The steroid type may be different names in your departments that you go to. I think we've used Kenalog 40 in the past. But the way sort of equipment and funds are going right now, I don't know the name off the top of my head. But it could be specific to what the doctor has requested. Aspiration. The only real difference, again, is that instead of injecting in, we're going to aspirate out. So patients with their big concern of a septic joint where the infection is in the joint or synovial fluid, they're going to want to draw out some of that fluid and send it to the lab for testing. So the patient may be having fevers and joint pain, swelling, redness, warmth. So the arthrogram starts just like normal and then ends with us aspirating some fluid out, sending it to the lab. Make sure the lab orders are in the computer before you start. Lesson learned. And then the fluid will need to be capped and put in a biohazard bag and labeled and sent to the lab.